As a reminder, your 3 CPCQC project leads for this learning collaborative are Elena, Amber, and myself. If you can't remember who to email, you can always email info@cpcqc.org and several of us will get it and we can triage your needs from there. But we are the main points of contact for this learning collaborative. Lastly, next, want to show you all some of your peers who are in this group. So we are happy to say that we have 19 hospitals in this learning collaborative and growing. And we have 3 hospitals that are in Montana who we love. And then the other 16 hospitals are in Colorado, and those 16 hospitals in Colorado account for 48.2% of all Colorado births. So we're very excited that so many lives in Colorado, L&Ds, can be touched by this work. And again, we're always growing, and we'll certainly have more teams joining, and we can spread this impact even further. So just to go over pretty quickly some key program dates. Again, you'll get all of this information via email, so it's okay if you don't commit it to memory. But what this looks like is the top in yellow, those are the data deadlines. So quarterly data at the end of each quarter, calendar year quarter. And then we ask teams to do a check-in with CPCQC once per quarter. So usually that's with at least Amber and, Amber, Elena, and the project leads that you saw. For anyone who is new to your project team, or even if it's new on your staff, we definitely recommend in the first few months of this program, taking part in a free SBIRT training with our friends at Peer Assistance Services. They offer totally free SBIRT training. We've worked on a perinatal specific training with them, designed with perinatal patients in mind. And you can schedule that for your staff on your own time. They also have open public ones that anyone can come to that are not necessarily perinatal specific, but we definitely recommend that as many staff members of yours as possible get this training. There is CE involved, and we will certainly connect you to our friends at Peer Assistance Services. Adam Maselowitz is the lead trainer that we work with there, and we recommend you take that training. And then lastly, we have monthly coaching calls as usual. Today is our first one of the year. Next. Key dates again, monthly coaching calls, quarterly one-on-one check-ins with us, and then quarterly data reporting. Just to give you a glimpse of some of the coaching call topics this year, and we're trying to be, we definitely want to be agile and responsive to your needs, your requests, things that come up in the world. So these are subject to change, but this is the loose outline to give you an idea of some of the exciting things we have happening this year. So I won't read them to you, but we're excited to be able to, as always, talk about, substance use specific topics. And then this year, now that we have Amber, have someone who can really lead us on the QI principles involved in all of this and help us implement through QI principles. Which brings us to a poll. So we, for this particular initiative of CPCQC, have never consistently had CE for our webinars, but it's something that we've been able to do through partners on some of our other quality improvement programs. So if you could please look at the poll in the chat and let us know if you value CE credits. It would help us because they're a little bit difficult to get, but we're willing to get them for sure if you find them helpful. So nursing and social work CE is the easiest for us to get, and then it's a little bit harder for us to get physician CE. So it's super helpful to know if that is a useful incentive for you and to get people to attend.
I'll just leave it open for a little bit longer. It looks like right now the poll is saying that 82% of people do value the Cs for the coaching calls. So I think that's really useful information for us. I think we'll probably try to do it for the rest of the coaching calls this year. So I appreciate that. Okay. Oh no. Hold on.
First tab.
Ah. We're back.
Great. Okay, so I want to remind everyone of the major goals for this year's Learning Collaborative. So most hospitals that are in this Learning Collaborative today have been involved for at least a year, and many of you have been involved for 2 years at this point. So we want to reach beyond now just making sure everyone is being screened and really start going more towards sustainability, and also making sure that all patients who do screen positive receive the comprehensive care that we need to provide. So the first goal is let's reach sustainability in screening. So what that means is at least 90% of all patients admitted for birth are screened for substance use for 3 consecutive quarters of data collection. The second thing we will talk about, and Amber will dive more into this later, is establishing a multidisciplinary work group that crosses the continuum of care to be able to regularly identify and implement best practices on issues related especially to perinatal substance use. So we'll talk more about that later, but we're really focused on helping hospitals this year get to a place where there is more collaboration across inpatient and outpatient settings for patients who are higher risk. And then lastly, we really want to improve our clinical care practices for any patients who do screen positive for substance use on L&D. So that means doing a social work consult prior to discharge, making sure that they have a postpartum visit scheduled, and then counseling them on recovery treatment services, naloxone, and medication for opioid use disorder. And where they are receptive to it, either referring them to those things, or if you're able to provide them in your hospital, making sure they get those things before they leave the hospital. And we'll get a little bit more into that as we go forward in the slides. Okay, which brings me to, we have a couple of very exciting new offerings this year to help all teams reach their goals. And I'll go into each one, but we have a new QI awards program. We have a new opportunity for MOUD technical assistance training. And then we also have some very exciting data improvements. So this is our new QI awards program. We will have 2 types of awards. So I'll talk about quarterly awards right now, and then the next slide will be yearly awards. But we really want to incentivize hospitals that are putting in the hard work of submitting their data on time, coming to the webinars, coming to the one-on-ones. So the first award is a Data Star Award. So if you submit all of your data by the deadline, and you can read what the details are of that, your hospital will get $200 to be used for staff appreciation that quarter. Additionally, we have a Collaboration Star Award. So if your team sends or has at least one one-on-one with us, and then sends at least 1 staff member to every coaching call in the quarter, you will receive the Collaboration Star Award, and you will again get $200 per quarter for staff appreciation for that. So that means you are eligible to receive up to $400 per quarter for staff appreciation because of engaging with the calls and webinars, or submitting your data on time, or hopefully both. And then secondly, we'll have annual awards. So, and again, we'll send the details on this afterwards so you can read more about it, but we'll have an award for excellence in quality improvement. So that is outcomes improvement on the key goals for this year for this collaborative. We'll have an award for excellence in collaboration. So again, that means basically showing up to all of the coaching calls and all of the one-on-ones. We'll have an award for excellence in data for submitting your data every quarter. And then we'll have the last one is a perinatal luminary award, and that's really to recognize teams that are going above and beyond or doing something really interesting or special related to caring for patients with behavioral health concerns. So we're super excited about these. We hope to be able to put on an end of the year awards banquet so that your hospital can receive this award. And we also want to help you generate press to make this worth your while and make it something that stands out to your hospital administration. So we will be working on figuring out how can we, help you tell your hospital administration about this. Do some press kit stuff for you so that you can send this to the local newspaper and get some recognition for your hospital. So these annual awards will certainly be a work in progress. There also may be monetary incentives tied to them, but we can't say for sure yet. It'll depend on our evolving budgets, but we hope to be able to give some monetary awards in addition to an end of year awards banquet. There are some FAQs related to these quarterly awards, which again, you'll receive this in your email. The main things here are that we want you to use these quarterly awards to reward the staff and to spread awareness of your participation in this program among staff. Also, if you're like, wait, we participate in SOAR too, can we get awards for SOAR? Yes, we are also going to be unrolling awards for SOAR. And if you're attending the SOAR forum tomorrow, you'll hear more about them. So you can get awards for both programs that you participate in. And yeah, we'll move on for now, but we're very excited about that. Next, exciting offering to help you reach your goals around getting patients to receive medication for opioid use disorder, ideally while they're still admitted in the hospital, and also to get them to be able to give take-home naloxone to those at-risk patients. We have a very exciting new offering this year. It's actually through CPCQC has a separate program called Impact Behavioral Health, and that is what this new initiative is through. It's funded by the Behavioral Health Administration. And essentially, you will get really hands-on technical support from some experts on medication for opioid use disorder on the inpatient side, and also dispensing take-home naloxone. Each L&D will also receive some sort of incentive for this, which will be to be determined in the future, but you can count on that there will be some incentive for your team to participate in this very hands-on process. We have our friends who will be leading that work here with us, Dr. Kaylin Klee, Rachel Duncan, who is a pharmacist, and then Dr. Don Stater is also here, and that team will be spearheading this work. Feel free, if you have any questions about that, because they're here, feel free to ask in the chat about what that might look like, and please contact us if you're interested in signing up. And lastly, a hospital does not need to participate in COAM-SUD in order to take advantage of this new MOUD technical assistance program. So if you're part of a hospital who isn't actually registered for COAM-SUD, or if you have friends at a different L&D who aren't in COAM-SUD but might be interested in this, they're very much eligible to participate. It's a statewide program funded by the Behavioral Health Administration. And lastly, and then we'll move along. I think I'm actually right on time, which is amazing for me. We have two very exciting things related to data improvements. Number one is that we're rolling out new ways for you to receive your data. So in the past, hospitals received a static PDF of their data visualizations, and we are now moving to interactive new online dashboards that will hopefully provide you more value, so that, you know, we really appreciate all the time and care you put into submitting data to us, and it is very useful, and we want to make sure you're also seeing the value out of submitting that data to us and really being able to use it to make improvements, which is what QI is all about. And then secondly, and this is a little bit longer term, but we also have funding this year through a new HRSA grant to explore ways to make it easier for our hospital teams to submit data to us. Some of this might involve looking into EHR integrations. It could be a whole different menu of things. But be on the lookout. We will have at least a survey, and then potentially we're working with this awesome consultant who's an expert in EHR integration and automation, who is going to be helping us sort of figure out what this might look like. So be on the lookout. We'll ask for your team to take a survey to help us understand sort of like what makes submitting data hard and what can make it easier. And then we also may or may not have some teams meet one-on-one with this EHR consultant. So we really appreciate your time now and engaging with these efforts with us so that we can figure out how to save you a lot of time later. So we're excited that we have funds to really look into this and implement it at some point in the future, but we could just use your help gathering information now to learn what would be most useful to you. And I think that's all for me.
Yeah, and I just wanted to step in. Our presentation that's supposed to be next is from Dr. Kate Feller, and she's actually coming from clinic. So we're not 100% sure on her timing. So I'm just going to keep going ahead. But when she jumps on, we'll switch back to her presentation. So in my brief amount of time, I wanted to walk us through the new data dashboard. And just really kind of go step by step so that you know what to expect when you get your data dashboards next week. So I'm going to stop sharing for a second so that I can get the dashboard pulled up. Okay, keeps putting me onto different screens. Feel like I would have gotten better at technology by now, but they love me. Okay, can you all see that? Yes. Okay, so when you get your dashboard, it will come as a link. Eventually, we're working right now to revamp the CPCQC website. So eventually it will be a log-on portal that you'll have a customized login for your specific hospital, and then it will populate the same dashboard, as well as any other dashboards that you have for other programs that you're participating in. But this is the SUD dashboard. So you'll first jump onto this homepage, and this is kind of giving you a general overview of where you're at with screening and your implementation of specific screening tools. So at the top, it has each of your screening tools and your screening rates over time. And on the right-hand side here, you can see all the different screening tools. And for example, this hospital, you can't see their depression screening because it's overlapping with anxiety. So you can click on and off different screening tools so you can see them specifically. And then if you go down, you can see each of your different screening tools and the stage of implementation you're at. So for this one, they fully implemented the substance use screening, depression screening, anxiety screening, SDOH screening, but they haven't started ACEs. So that will show over time as well. So at the top, you have each of these tabs. So the next tab is specific for substance use screening. So the top of this funnel shows the total number of patients admitted for birth that quarter. Then it will go down to the number of patients who were screened for substance use out of the total number of admitted patients. And then at the bottom, it will have the number of patients out of the patients who were screened who were positive. So going down. And then on the next page, you'll see of those patients who screened positive for substance use, the number of them who completed the patient level forms. So those of you who aren't familiar, any patient that screens positive for substance use, we have a secondary form to walk you through the clinical care practices to do brief intervention and referral to treatment. So of those 25 patients who screened positive for substance use, 9 patient level forms were completed. And we can see for this hospital that the substances that were used are here in like this pale green color. And in the form multiple, it's like a checkbox, so you can select more than one substance. So they're not going to equal up to 9. And then we have specific patient level conditions, so number of out of hospital births, number of patients who had no or unknown prenatal care, and then number of patients that left AMA. And then we have just specific demographics for patients who screen positive for substance use. And then we go to the next tab, and feel free to jump off mute if you have any questions. I think Katie will be monitoring the chat, but you can also just jump on and interrupt me. So this next tab is going into patients specifically who are screened for substance use. So in the top here in the text, we have the criteria for if a patient does screen positive for substance use, what you're supposed to do. And it walks you through this on the patient level form. But just to go over the steps again, once a patient screens positive on your screener, that patient should be consulted by social work. If you don't have social work, have a consultation with a nurse that's more in depth and really goes into what this positive screening means. This patient should then be counseled on recovery treatment services. And then the patient should either receive recovery treatment services during the birth admission, or if they already received it prenatally, or they're referred to the recovery treatment services. And then lastly, we really want to make sure that these patients don't slip between the cracks. So make sure a postpartum visit is scheduled during that birth hospitalization or during the first 24 hours after discharge. So knowing these steps, that's what we're going into in these little boxes. So there was 9 patients who were positive for substance use. 9 of those patients received a social work consult. 8 of them were counseled on recovery treatment services. 3 received recovery treatment services, 5 were referred to recovery treatment services, and then 2 postpartum visits were scheduled. So of those patients that went along that continuum, only 1 patient met all 4 of those clinical care practices. So for more of a visual of this, you can scroll down, and I'm sorry it's cutting it off. But each of these blobs or circles represents each one of those patients who screened positive for substance use. And so that 1 patient who met all those clinical care practices is green. And then the other patients here are all red because they didn't meet the clinical care practices. But if you hover over each of these patients, you can see kind of what happened, where they slipped through the cracks. So for this patient, no, it was unknown if a postpartum visit was scheduled, but they were consulted with social work and they were referred to recovery treatment services. So this patient is doing great. They were referred to the services they needed. They were consulted on it, but we just didn't have that postpartum visit scheduled. I mean, you can go through and see each of the patients. And if, for example, if this is your hospital, you could say, okay, we're really missing out on all those postpartum visits that are being scheduled. So what can we do? What PDSA cycles can we implement to work on that specific gap? So that's one area. And then the next tab is going more into medication for opioid use disorder. So similarly to the previous tab, you see at the top the criteria. So if a patient screens positive for opioid use during pregnancy, the patient should be counseled on medications for opioid use disorder. And the patient should then either receive medication for opioid use disorder or is referred. So same format as previously, we see the number of patients who screen positive, and then the number of patients that received appropriate clinical care. And this one is a little bit funky because it's just based on the number of checklists received and if the checklists were completed appropriately. But so you'll see that 4 patients were counseled on medications for opioid use disorder, but only 2 actually had opioid use. So that just might have been an error in completion of the checklist. But if we scroll down again, we can see the 2 circles of the patients who screened positive for opioid use. This one, it was just unknown across the board. So technically they didn't meet the criteria, but a lot of it is unknown. So that's why it's gray. And then red, they also didn't meet the criteria. And it's also because everything was unknown. So going back up to the top again, the last tab is for naloxone. And I want to build out this tab a little bit more, but I just haven't had a chance to really fully think about how I want it to look. But we can see 4 patients were counseled on naloxone, 0 patients were prescribed naloxone, and 0 patients received naloxone. And so not every hospital will have robust data on this tab because some of the hospitals are not participating in the Colorado Naloxone Project. But I think this is a really good overview of just kind of seeing where you're at with your naloxone distribution. And so overall, in each of these tabs, you might have seen on the top this little reference box that says quarter. So you can always go back and refer to previous quarters that you submitted data for. You can also select more than one. So if you wanted to see how you've been doing throughout the collaborative, it will just compile all the data together. So that is the new data dashboards. And you will be getting those in your inbox next week that are specific for your hospital. But if you have any questions about them, if you're having trouble navigating them, if you want to see another visualization that I haven't made, feel free to reach out to me. It's a work in progress, and I want to make it so that it's really useful for you. So please reach out to me if you have any questions. So I'm gonna go back to the slide deck, and I haven't seen Dr. Feller jump on. I don't know if you have.
I haven't seen her.
Okay. But if she jumps on, but we'll skip ahead to Amber. Okay. You all see that?
Mhm.
Okay. I'm gonna give Amber slide control. Well, maybe not. So you can go ahead and I'll keep skipping ahead for you.
Hi, everyone. I've met most of you. I'm Amber Johnson. I work as the quality improvement coach. And as a team, we've decided to devote at least a little bit of time at each coaching call to talk about quality improvement. And the reason that we're doing that is because we're a quality improvement program. And we really feel that it's important to make sure that the teams have the tools and the resources and the knowledge that they need, because really the outcomes that we're expecting for you to deliver on require quality improvement principles. But I really wanted to start today, the first coaching call of the year, just by doing a very basic quality improvement 101, because I think it's important to level set what we mean when we're talking about quality improvement and why we think it's so important. So in 2017, at a time when maternal mortality was declining worldwide, the World Health Organization reported that the United States was one of only 2 countries, including the Dominican Republic, that reported a significant increase in its maternal mortality ratios since the year 2000. We spend more than any other country on hospital-based maternity care, but our maternal mortality rate ranks last among industrialized countries. Our maternal mortality rate ranked last among industrialized countries, and this is more than 3 times the rate of other high-income countries. The United States stands out as having the highest cost and the lowest performance. And we're here today because bad situations like this, if we leave them untouched, then they typically don't just stay unchanged, they get worse. So the baseline data, I hope that I'm making this clear. The American obstetric care system just isn't working. We also know that the data shows clear disparities in the care that we're giving. The United States maternal mortality rate is exceptionally high for Black birthing people, and it's more than double the average rate and nearly 3 times higher than that for white birthing people. In other industrialized countries like Norway, maternal mortality is extremely rare. So Nina Martin is an award-winning journalist, and she just happens to be our keynote speaker for our annual conference in May. But she reported that in Great Britain, the rate of maternal mortality has declined so dramatically that a man is more likely to die while his partner is pregnant than she is. What this data tells us is that clearly there's a better way to provide maternal health care, and a way that actually saves lives. And certainly in America, we haven't mastered it. In Colorado, bringing it closer to home, the maternal death rate has doubled since 2008 when I moved here. The most common single cause of maternal mortality in Colorado is suicide, and that's closely followed by unintentional drug overdose. And it's interesting to me as an obstetric provider because these issues eclipse the familiar obstetric issues that I'm familiar with, like infection and hemorrhage and hypertension. 80% of the maternal deaths are considered preventable. And what we mean by that is that there is at least some chance that this death could have been preempted by a change at the patient, community, provider, facility, or system level. Preventable maternal deaths due to maternal health conditions to me, as an obstetric care provider, are an unavoidable call to action, because the truth is that our actions actually save lives. So when I give an elevator pitch, for quality improvement, I typically use the words, quality improvement is the systematic reduction in the variation in outcomes, which I realize is a super nerdy way of saying that QI helps us to achieve consistently positive outcomes, regardless of age, race, ethnicity, hospital, season, weather, healthcare provider, moon cycle, all of these things. A frequently used expression to describe system performance is that every system is perfectly designed to get the results that it gets. And what this means is, as we just discussed in the previous slides, in the United States, our healthcare system is perfectly designed to increase our maternal mortality rate. And in Colorado, our system is perfectly designed to not meet the needs of pregnant and postpartum persons with substance use disorders. Healthcare quality improvement, we owe our existence to other industries. QI principles were actually developed in automotive and aviation manufacturing in the 1940s. Quality improvement, and specifically continuous quality improvement, is the reason why air travel accounts for just 6 out of 1,000 deaths per billion miles of travel. Flying is the safest form of transportation, and it's far safer than driving. And this success is only just beginning to be translated into the healthcare sector. I'll give you one quick example, is that the aviation sector uses checklists to ensure that there is safety. And those similar types of checklists have been translated into anesthesia practice. And this has saved lives by decreasing human errors. But I really want to be clear here. I am not equating patients with machinery. I have delivered 1,000 babies and have never flown an airplane even once, but I know that caring for patients is radically different from building cars and flying planes. Healthcare, the way that we provide it, it requires intimacy. It's complex. It requires sensitivity. We have to be compassionate, empathetic. We have to build trust. Healthcare truly is more like 20 different industries, many of which need to seamlessly interact throughout the patient's healthcare journey. And for me, I really think that this is the best argument for improving quality improvement and introducing those principles into the care that we're giving. In 2001, many of you are familiar with the Institute of Medicine report that stated it now takes an average of 17 years for new knowledge generated by randomized controlled trials to be incorporated into practice. And even then, the application is highly uneven. What's clear here is that our current approach to improvement is not nearly as agile as it needs to be. And quality improvement is the tool that can bridge this gap between research and clinical practice. As a pragmatist, what I love about quality improvement is that I think it's a direct action plan to address the most common causes of maternal morbidity and mortality. Quality improvement is truly the front line of addressing the most impactful influences for perinatal care. And as an added bonus, and again, as an obstetric provider, the research shows us that providers who engage in QI activities experience less isolation, lower stress, and lower dissatisfaction with their jobs. So again, around the same time, 22 years ago, the Institute of Medicine identified 6 domains of healthcare quality. And those 6 domains were so comprehensive that today they're still the dominant framework when we think about improving and measuring quality in healthcare. I want to run through those domains pretty quickly. Many of you are familiar with them. But I also, while I'm doing that, want to give examples of how those domains actually interact with our healthcare system, because it's easy to look at those 6 domains and say, of course, that's what healthcare is, and we probably meet a lot of those domains. The first is that quality care should be safe. It should avoid injuries to patients from the care that is intended to help them. The fact here is that 1 in 10 hospital patients are harmed while receiving care. Quality care should be timely. We should be reducing wait times and harmful delays for patients and providers. A 2017 study showed that 24 days was the average wait time to be scheduled for a physician appointment in 15 of America's largest cities. Quality care should be effective. It should provide the appropriate level of services based on scientific knowledge. The New England Journal of Medicine reported that a little over half of the care in the United States follows evidence-based guidelines. Quality care should be efficient. We should be avoiding waste, including the waste of equipment, time, ideas, supplies, and energy. The fact here is that if US physicians' administrative costs were similar to those of our neighbors up north in Canada, the result would be $27.6 billion in yearly savings. And finally, or two more, quality care should be equitable, and that care shouldn't vary in quality because of personal characteristics. And again, here in our home state of Colorado, people of Native American descent were 4.8 times more likely to die than non-Native people who gave birth during the same period. And finally, quality care should be patient-centered, and that means we should be providing care that is respectful of and responsive to individual patients. This one might be my favorite, and even though it says physicians, we should count all providers into this. The studies of physician-patient interactions show that physicians listen to patients' concerns for an average of about 20 seconds before interrupting. So I really don't want to end on a discouraging note here. So I want to take like a quick minute to talk about how quality improvement can help us. So CPCQC, we use the Institute of Healthcare Improvements model for improvement to structure all of our quality improvement projects. And using this model, we start by asking three key questions. The first is, what is it that we're trying to accomplish? The second is, how are we going to know that change has led to an improvement? And finally, we ask, what changes can we make that are going to result in an improvement? And for co-AIM-SUD, which we're here for that today, some of these questions are the same for our entire cohort. Our aim, of course, is to screen every birthing person for substance use during their hospital admission, and then to provide the appropriate clinical care for all of those who screen positive. And then to do that, we're measuring screening rates, clinical care practices, some of the important demographic data that help us identify disparities in care. But for the last one, each site probably has their unique change ideas that they're going to implement in order to make change at their facilities. The Plan, Do, Study, Act cycle, or the PDSA cycle that you often hear us talk about, it's just a framework for trying out evidence-based change ideas on a small scale before learning from those changes and then trying them again on a larger scale. What we like to say is try something, and if it works, try it again, only bigger this time. So that means try a change idea on one shift. Go ahead, and if it works well, try it for a quarter. If it works well, do it for the entire month, spread it through the hospital. It's really the scientific process in action here. We're going to come back to this model for improvement again and again this year. I just wanted to introduce it here for you. I'm going to end our talk quickly here by just demystifying PDSA cycles. By getting a little vulnerable and showing you some examples in my life this month about how I've done change ideas and PDSA cycles. Go ahead. So exactly 1 month ago, I set my alarm for 5 a.m. and I went to an early morning exercise class instead of my usual evening class. The rest of the day, I felt great. I kept that schedule up the rest of the week. I felt like I had more time with my family in the evenings. And now I'm 1 month in and I think I'm converted. I'm a morning person now. That was a PDSA cycle. Second, I had my 13-year-old cook dinner last week instead of cooking it myself. Unfortunately, it ended up taking longer and it tasted awful. So I'm going to schedule him for a cooking class and we're going to try it again in a week. And finally, instead of making a running to-do list for the day, I set aside time before starting my day to make that list. That day, I felt really productive. I felt less distracted, and I'm going to try this again for the rest of the week. These are PDSA cycles. We try them all the time in our daily lives, and this is what we're asking you to do with change ideas at your facility. So I want to provide you guys with some guidance this year. We really want to make QI relevant to you. I don't want it to be a mystery when we talk about it and talk about the tools that we use for it. So through the coaching calls, we're going to spend some time each session giving you guidance, tools, skills. The one-on-one sessions are for mentoring. We can talk about things more specific to your site. And today I'm going to go ahead and give you guys some resources. Go ahead, Elena. One is that we created one pagers. The first one on the left is a one pager for your RN workflow for managing a positive substance use screen at your facility. We heard from many of you that the nurses don't always know what to do once they have a positive screen, and it can feel overwhelming to them, especially if positive screens are relatively rare at your facility or you have lots of staff turnover. So this one pager on the left here is great to hand out to your nursing staff to post in your nursing lounge to keep with your screening tools. There's a QR code. We'll email these. The one on the right is just a basic one pager all about SUD. So it talks about SBIRT. It talks about what we're doing and why we're doing it. It gives some resources at the bottom. Again, for those of you who have traveling nurses, new providers, turnover, new orientees, this is a great just one page resource for you to hand to them to introduce them to what we're doing here. Katie told you that we're talking about multidisciplinary work groups, and we're going to come to this again and again this year. This is kind of a basic diagram of what we're thinking of when we say multidisciplinary work groups. So here we've sort of listed, when we say multidisciplinary, we mean inpatient clinical care providers, we mean outpatient kind of clinical care providers, and we also mean social services and mental health care providers. And so I want you all to look at this over the next month and start brainstorming at your facility who would fit into these categories and who is it that you might start recruiting at your facility to participate in a work group to support the work that you're doing around substance use and pregnancy. The workflows are along the left side. Those aren't exactly what your work group needs to do, but they are some suggestions. If you're recruiting and you want your recruits to know what is it that you're asking me to do, those are some of the ideas of what we're asking multidisciplinary work groups to do. And I think that might be it for me. I am always around, so please email me if you guys have suggestions, if there's needs that you have at your facility for quality improvement. I'll be back next month with more QI activities for you.
Okay, oh my goodness. Okay, so I wanted to jump in. I just got a text from Dr. Feller and she's stuck in clinic. So that's a bummer, but I will try to get her on a future coaching call because her story is really impactful. And I think it tells a little bit of a different perspective than we might have heard before. But before we let you go, here are just some next steps. So make sure you're registered for our monthly coaching calls. I also send it to you as a Google Calendar invite. So we're trying multiple different ways to make sure you have it on your calendar. If you don't see it, email me. I'm also going to send it out in the follow-up email after this with the registration link. But just make sure it's on your calendar. I'm really excited about what we're offering this year. It's a lot of different topics, so I'm excited about that. Make sure to put on your calendar the data deadlines for COIMSUD. I've also added this to your calendar through Google Calendar, but make sure if you don't see that, you can email me or add it yourself. One of our awards is if you do all 4 of your quarterly check-ins, you get a year-long award. So we really want to make sure that you're keeping up with this. So instead of the qualitative kind of surveys we were doing monthly, instead we're doing the quarterly one-on-ones. So this will just be a check-in with our team, see if we can help you, and see kind of what brainstorming options we could get for you. 4, new hires, or if you want a refresher, schedule an SBIRT training with Adam. 5, if you are interested in MOUD training, reach out to our team and we can connect you with Dr. Stater, Dr. Klee, Rachel Duncan, and they are going to be able to give you some technical assistance for implementing MOUD in your unit. And then lastly, we have 2 surveys that we're going to be sending you. One is the follow-up to the survey that we sent out last year on labor culture, and it was specifically for nursing staff. And so we're doing a follow-up survey on that to see improvement. So I'm going to attach that to an email in the coming weeks. And then as well, we also have a clinical care survey that Amber created. And so just be checking your inbox for that as well. But I know this is a lot, but I'll put it all in an email for you that you can refer back to. And hopefully we can achieve all these things this year.
And before we go, so we made perfect timing, but unfortunately, since Dr. Feller can't join us, for better or for worse, we have an extra 10 minutes. So I know I went through earlier that new MOUD program pretty quickly, but since we have our friends here from Stater Opioid Consultants, I'll definitely turn it over to Dr. Stater to fill you in a little bit more on what it is that we're talking about. And we really hope that your hospital will sign up for this new offering.
Well, thank you, Katie. It's such a pleasure to be able to have a few minutes to really discuss some of what we aspire to provide to hospitals that are willing to work with us and eager to provide this new service to pregnant persons. I will say that this is one of the most striking and important services that we can be offering to pregnant persons in Colorado. And you heard that the importance of doing this, given the fact that suicide and overdose are the #1 killer of pregnant persons in our communities. And right now, I'd say that there's a tremendous disparity between the need and our actual ability to provide these services. And one thing that I was just thinking about, and now that I'm on the spot, I'm just going to share some of these thoughts, is, we often call suicide and death by overdose deaths of despair, right? That's a common term that we hear from it oftentimes. And going back to Amber's point, that the system is creating exactly what the system is meant to create, is that these don't have to be deaths of despair. And really, from the medical perspective, these are not deaths of despair, they're deaths of neglect. And they're deaths of neglect because we've neglected this disease process for so long that pregnant persons who need this treatment simply just aren't getting it. And I think that's really a call to all of us who work in hospitals and who've both taken an oath to care for the sick, but that hospitals have taken a commitment to care for their communities, that we're falling short of some of the things that we aspire to do. And really the ability to be able to provide these services to pregnant persons, I think you'll find is not only fulfilling work, but is sorely, sorely needed in all our communities. So if you do not have a program currently that reliably can provide treatment to pregnant persons who screen positive, or provide naloxone to persons who screen positive for use disorders, then we are super, over the moon excited to work with you to talk about how we can stand up these services and provide this life-saving medication, et cetera, to some of the patients that you serve. Okay, so that's my introduction. I'm going to pass this over and also put Dr. Klee on the spot as the preeminent, I think, physician in our state that provides MOUD services to pregnant persons and is proudly part of our team. And I wanted to ask Caitlin if you wanted to give any other thoughts.
Yeah, no, thank you so much. This is really exciting, and I think feels personally really important to see that our healthcare systems and our state really catching fire. I mean, I think maybe none of us have flown a plane, and you might feel like maybe the first time you start Suboxone or methadone for a pregnant person in the hospital, it's like you're flying the plane. But who's not stressed about flying planes is pilots. And so, right, you keep practicing. And I have found that our patients are incredibly gracious often when we're trying to do the right thing and to help people where they're at, and we're working out the kinks in the middle of it, right? I've definitely had patients teach me so much along the way about what works and what definitely doesn't work. And so you are not alone in feeling like if you're being asked, or if your hospital or your patient population is asking for more access to treatment medications. I love the flying the plane. It might sound scary, but maybe it's the safest method of transportation. And I'm going to remind myself of that every time I fly. So thanks so much. This is just a tremendous opportunity to be involved, both with COIM-SUD and supporting that work. And now moving beyond naloxone only. I think naloxone helps us build bridges with people who otherwise may have left our care physically and emotionally empty-handed, right? So feeling like we're able to offer a medication that is life-saving for either that person or somebody in the community, but then even more life-saving to be able to partner that, dispensing of naloxone from our L&D units with initiation of medications to prevent overdose death and hopefully help folks move towards their health goals, which for some people includes a life of recovery. So thanks so much. And I am happy to introduce Dr. Rachel Duncan, who is the co-chair for the Colorado Moms Initiative, which is the Maternal Overdose Matters initiative that's bringing you naloxone to your hospitals and leading the charge around bringing MOUD to our birthing hospitals as well.
Well, thank you, Dr. Stater and Dr. Klee. I don't have any great analogies, any better than those flying the plane, but I think we're very passionate about this. So many barriers have recently been removed to providing this. The X waiver is now gone. We can teach our OBs and our PCPs to manage these folks on the outpatient side. And I think that's been one of the main barriers to initiating MOUD on the inpatient side, particularly for pregnant and perinatal women. And so I'm just so thrilled about that aspect of it and being able to help stand that up in communities and hospitals and being able to create this environment where any pregnant or parenting patient feels very accepted, very welcomed, and very cared for. I'm particularly passionate about bringing this to every county and region in Colorado. It's not just the Front Range, right? It's all the rest of us, the rest of the state. I live in Chaffee County, and so very passionate about bringing this to our rural and critical access hospitals too. This needs to be in all 48 birthing hospitals in the state. A pregnant or postpartum patient needs to be able to feel welcome in all of those hospitals, have this initiated, go home with naloxone, and be connected to treatment. And so I think that these three initiatives go really well together, and we'll be so excited for those that want to be on the forefront of this, get a hold of us, because we'll be reaching out to get some pilot sites to get this going, and to continue on the great success of CPCQC and SUD, the Moms Project, and now the MOUD portion. So very excited to work with you. Please reach out if you're interested.
Yeah, it looks like Dr. Stater just put his team's emails in the chat. So again, if you want to contact them, you can contact them directly. And I'm also happy to serve as the middle person. If you lose those emails, I can always connect you to their team as well. So if you have any questions for them, we have a few minutes, so you're welcome to come off mute or throw a question in the chat. But if you don't, I'm also happy to connect you later on. Okay, well, thank you all for attending today. We were really excited to start off the year and also start off the year in person. We're working out the kinks a little of in-person virtual, but we are really excited to see you all today and share some exciting new things we're doing for SUD. Our next coaching call will be in March, and I'll forward all that information in the follow-up email. But thank you all again for attending, and we hope you have a great rest of your day.
Please complete the poll.
Yeah, complete the poll.